questions. There are a lot of questions, people, and concerns as well. It's only normal. And Dr. Willis Akhwale and Dr. Dan Gikonyo and Dr. Joe Bogira, they're all here trying to reassure a nation going forward. Now, Dr. Willis, let me ask you this. Are there still vaccines left in Kitangela, or were they all distributed?
No, there are still some vaccines there. Immediately, we distributed 492,000 doses because frontline health workers are estimated at 450,000. We then distributed some vaccines to our security forces. And now, last week, when we got about teachers and they are being vaccinated within posts, again, estimated number of those who are above 50 years to get vaccinated. So there's a very meticulous management, stock management. And the reason is because as you go down the cold chain in the lower levels, you must really be sure that there's space to put these vaccines in the refrigerators within the clinics. Up within the regional stores and in Kitangela, we have a lot of space. So we can hold the vaccines in those places, but ensure that we are able to distribute through the vaccination posts when they account for what was given and it goes. And this is important. A number of considerations really to take note of. One, there's also, one has to take care of this vaccine. This is a liquid which has no preservative. It should not be shaken before one is injected. So people should not expect when they go to the injection, the vaccination, that somebody will be shaking a bottle and a syringe and pumping it to their hand. This particular vaccine, others may have other different qualities. So that's one. Number two, once you've opened that vial, it vaccinates 10 people. And if you don't get 10 people, maybe you vaccinate 4, within 6 hours, the vaccine expires. So you have to discard it. So you start getting a bit of wastages. So for example, the 450 healthcare workers, we have to cater for some kind of wastage because it may. But that's why we are training healthcare workers to reduce that wastage. And that is why we are trying to see other priority groups coming so that there's minimal wastage. So these are a lot of considerations we put in place.
Tell me something. Has the distribution been a logistical nightmare? Has it been difficult?
For this first phase, it hasn't. In fact, very smooth. In fact, my task force had estimated 2 weeks to get the logistics. We did in 1 week. Thanks to a lot of government support and partner support, people like AMREF were able to send the vaccines to Mandera, and also some of our security forces have been very helpful to get things moving. So we took actually 1 week. Instead of 2. Our vaccination was to begin on 15th, it began on 8th. So, but as the vaccines, especially when we begin July, when we are now looking at almost 10 million people to be vaccinated, then the issues of logistics will start. They will test us, but I think we'll have got the experience.
Great. Let's go to Karen Hospital and Dr. Dan Gikonyo. Look, all these years that you've run Karen Hospital, let's face it, and you know, it's been an incredible journey. Have you ever seen anything as challenging as this virus?
You know, Jeff, it's 100 years since we saw anything like this in the world. There was a pandemic like this caused by the Spanish flu in 1918, 1919. That time, believe you me, 50 million people died. 50 million. Leave alone, you know, now in the whole world with this COVID disease, we have lost about 1 million people. In 1918, the world lost 50 million. I don't know whether those days you could count everybody, but that means they maybe lost more because they couldn't count people in your backyard of Kiambu and your uncle with a red hat, things like those.
Yes, exactly.
But you know, you can imagine how many people had died. So we haven't in our lifetime, no. But let me tell you something else that is really a big achievement. In the history of medicine, there has not been a vaccine that has been developed in the speed at the speed at which this COVID vaccine have been developed. Even when the epidemic started last year, the WHO estimated that it will be at least 1.5 years before you get a vaccine. But the world got really into business and we were able to get this vaccine in less than a year. Well, it's sad, Jeff, that we have not put the same effort into HIV when it occurred, because we'd have saved a lot of people, but that's a story for another day. But yes, we have not seen anything like this in the world all over. In fact, let me not digress in that area. Yes, I haven't.
But okay, let me ask you this then, Doc. How many waves are we expecting? Do we know how many waves? Obviously, nobody's been down this road before, but we're hearing that third wave, and then fourth wave coming, a fifth wave. I mean, explain to us.
We are not sure, but we can learn from the history of 1918. And remember, that's why I keep saying, in the holy book of Genesis, the good Lord clearly says, let us make man in our own image, and let us give him dominion over all the things in the earth, and even all the creatures that creepeth under the earth, which I believe includes viruses. So we have dominion over all these things. And even in 1918, the world still moved on. So with or without the vaccine, Jeff, believe you me, nature and the human nature and human beings will still overcome this. So it's not the end of the world, but it will keep on going wave after wave. Of course, new things can happen. It can be worse than 1918, we don't know. But the nature of the virus is that it keeps on changing and changing, and often it actually mutates to weaker types. Not only so, the body also learns how to cope with this. So although we are going to get waves and waves, I can see us naturally overcoming this pandemic. The vaccine will help, drugs are helping, but the good Lord and nature will find a way of fighting this disease. So yes, there will be waves, and they could be worse or better, but eventually, I think nature will overcome this thing.
Amen, Doctor. Well put. Let's just go from Karen back to Kansas City, and Dr. Job Mogire at the University of Kansas. Dr. Job, let me ask you this. You said earlier on you've been keeping a tabs on how Kenya's doing. You've been keeping a tabs on how the response has been. From your very strategic listening post over there, tell us your thoughts about how we've performed as a nation in general.
Jeff, the response to the coronavirus pandemic worldwide is a barometer on the health of the healthcare systems across the world. But one thing that has been unique when it comes to coronavirus is the added layer that the strong social sentiment, where social could be the impact on livelihoods, the influence of political utterances. So the added layer has determined what the pandemic looks like everywhere you go, whether you're in Europe or in Asia or here in the United States or anywhere in Africa. I have to say that I am so grateful that what happened in countries like here in the US did not happen in Africa. That's because I do not know how the population would have coped. Because I am in a country where we have the highest number of high quality hospitals compared to any other part in the world. In terms of the qualified healthcare workers and their numbers, one of the highest anywhere in the world. If you took the same intensity, severity of the pandemic that happened here, placed it anywhere else in Africa, it would have been a grave disaster. What has helped us? Number one, we don't move around as easily as people do in other parts of the world. Moving from Mombasa to Malaba will take you almost 2 days. That is helpful. Such that when the virus arrived in Kenya, it would take a long time for it to get from Nairobi to Mandela, from Nairobi to Busia. That's because this was a virus that is driven by travel, number one. Number two, we don't spend as much time indoors, and we don't depend so much on air conditioning, and therefore, generally, Kenyans and Africans in general, live in countries that are warm, therefore they move around a lot. And so when it comes to thinking about what is it that we have done as a system, the governance system, whether it's within the healthcare system or the school system, the transportation system, there have been limits. But I think if you look at what the situation was like already and weighed in the context of what could possibly have been done, there are many wins. There are many wins that this is a continent that is not economically unstable, but though it was painful, people were able to follow the government guidelines to socially distance. There are limits. I mean, if you're socially distancing people in a slum, it is very difficult. So the circumstances were difficult, but there are many wins which can be named. But on the flip side, there are also many opportunities that can be taken advantage of. And of course, it points back to strengthening the health system, from human resources to the facilities, realizing that just availing oxygen is not enough, that an ICU is not just a bed and a room. Those opportunities, if we continue to take advantage of those opportunities, there is greater promise. This pandemic has shown us what we can do as a people, but it has also shown us what we really lack that is critical, that can sometimes make a difference between life and especially for any patient who ends up infected with this very severe virus.
Absolutely. Good point there, Doctor. Good point. Tweets are coming in so thick and so fast. We're going to get to them right now. And Dr. Dan Gikonya, maybe you can answer this question by Dongo Wainaina, who says, is Kenya dealing with old COVID-19 or new variants that are proving more lethal in their spread?
Well, Jeff, the data available so far is that we are still dealing with our old initial COVID variant. The South African variant or the UK variant is yet to make a big impact on this part of the world. And partly so is because, as Dr. Mugere has said, movement in this part of the world is not very rapid, and therefore the spread of the new variants has not affected us that much. We are still dealing with the initial variant that was there, and therefore the vaccine can help us. Because as you know, the available vaccine, the Astrazeneca vaccine, is not very effective against the other variants that are emerging, like the South African one. We hope it doesn't get here into large quantities. But yes, we are dealing with the old variant. But even in our own local environment, this old variant can mutate and give us either a weaker or a stronger. We don't know.
Yeah.
Time will tell. You know, this disease is so new. So nobody can say that they have all the information about it. We learn as we move. We are learning as we go on. So what we are saying today may not be exactly correct tomorrow.
True that, true that. Okay, Dr. Willis Akwala, maybe you can answer this question by Andrew Mbogwa 001. How safe is the COVID-19 vaccine, and what's the process to make it safe for any nation?
Yeah, a good question. And I need to say that the vaccines that are approved under what you call emergency use authorization, what is considered is, number one, the effectiveness and the safety. Now, safety is then done during phase 2 and phase 3 of the clinical trials, and you assess how effective this vaccine will be. Let me say there's no vaccine that is 100%. But as Dr. Gikonyo said, for the coronavirus vaccine, especially reducing severe disease and death, all the vaccines under emergency use have proven to be 100%. They are able to reduce that. So then the question is, how do we monitor the safety? Today we explained in the media briefing that we have safety monitoring is through what we call pharmacovigilance that is run by the Pharmacy and Poisons Board. But it begins from the vaccination post. Immediately you are vaccinated, you will be asked to wait for 15 minutes so that they observe if there is any immediate reaction. And then after that you go, and you will be told if you don't feel well, you report to the healthcare worker who fills in a form or goes onto a digital platform, and that report is transmitted to the Pharmacy and Poisons Board. And today they told us so far they have received 43 reports, a lot of which is a feeling of headache, mild to moderate, some of the joint aches, but nothing. So these reports are then analyzed, and we have what we call the Kenyan National Vaccine Safety Advisory Committee, headed by Professor JKLIVE, and they look into this, and then they are able to make any decision as to whether there is need to do further investigations. But there's another way of doing the surveillance, what we call active surveillance. This one, the team from Pharmacy and Poisons Board can randomly select an area and want to go and interview people who are vaccinated and seek to know if they ever experience any side effect. So we have a very robust system and it's already in play.
All right, Dr. Gikonya, I'm going to ask you this next question because it refers to Kenya. And then Dr. Mugira, maybe you can comment if you listen to the essence of it. Jeremy Nyakundi saying, so far 13 EU countries, actually by this evening, it was about 20 EU countries, have halted AstraZeneca shots, citing formation of blood clots. What will these medical experts tell Kenyans if in the long run they find out that the vaccine causes blood clots? Dr. Gikonya.
You know, Jeff, like I said earlier, if you have the luxury of choice, you can choose other things. We do not have that luxury here to begin with. Number two, if you look at the number of blood clots reported on this vaccine vis-a-vis the number of people vaccinated, the numbers are low. We are talking about maybe about 30, 40 cases out of maybe 10,000 cases.
Yep.
So whereas it's true there may be some risk in the people that we are targeting, people at high risk, the consequences of some blood clot are much less than the consequences of being in an ICU unit for 10 days and sometimes dying out of this infection. So the issue here is, let us target the people who really are at high risk. I am not going to vaccinate school children because we know their complications rate, even when they get this virus, is very low. I mean, if you kids below 10, the mortality if they all got COVID is 0.1%. Whereas if you have comorbidities, the risk of dying from this disease is 10%, 1 out of 10. It's very high. The risk of these complications is not anywhere near that 10%. So, whereas, as I say, the vaccine is a foreign protein. And we all react to proteins. Even when you get a blood transfusion, people react to it. If you eat chicken, some people react to it. If you eat an egg, some people react to it. So these reactions can and will occur because we are injecting a foreign protein. Jeff, what you have to say is, which is worse? This reaction on the skin or joint pains or a little blood clot, which is worse, that or the complications of this disease in the high-risk people? And I choose to go with vaccinating the high-risk people because the safety and the people who are saved from serious complications and death are huge numbers than the ones who will get some reaction to the vaccine.
Good point, Doctor. Very good point. Dr. Mugira, you have, where you are, there's a choice of 3 or 4 vaccines. Let's say what? They say about 11% of Americans have been vaccinated, which makes it about maybe 40 million. Of course, there's bound to be side effects.
Jeff, first of all, commenting on the side effects reported about the Astrazeneca vaccine in Europe. You see, what we lose sight of the fact that 70 million people have been vaccinated. 70 million. And out of these 70 million, we have data reporting 30 blood clots. If you take the vaccine away and just look at the general population prevalence of blood clots, if you had 70,000 people, you would expect in 1 week to have about 5,000 to 6,000 blood clots without the vaccine. So in other words, in my evaluation of the data that I have looked at, I think there is an element of overreaction The Minister of Sweden, when he was making the announcement about halting the planned vaccine, he clearly stated that they would rather be accused of being overcautious than start running behind side effects, which means he recognizes that there is a good chance that this truly is an overreaction. Because if we are talking about 30 blood clots among 70 million people who have received blood clots, received the vaccine, and compare that to, you would expect thousands of blood clots ordinarily coming to the hospitals every other day. We run the risk of over-sensationalizing a few findings, which is why it really concerns me when the people who have received the vaccine start putting up daily updates every other day. Maybe it's because most of the vaccines we received them as children when we were taken to the clinic and held down and received the injection. We need to make the decision. We don't realize that our mothers actually stayed up awake the whole night giving us paracetamol and keeping us soothed. We eat nyama choma and we feel bloated. This is a vaccine that is going into the body system. So a little fever here and there, that is something to be expected for the price of getting the protection that we need. So overall, Europe and here in the US, the prevalence of side effects is not any different than what was seen during the studies, and there have not been any fatal reports of, for example, clots killing anyone.
Great, good point. And no growing a third eye or a second leg or something, none of that stuff, right? Okay, all right, don't even answer that. Dr. Willis, speaking of Europe, you were saying Italy and France have now restarted distribution of Astrazeneca.
Yes. That was breaking news today. And in fact, a lot of countries upon suspension, if they don't find any direct link, they are resuming the vaccination program. Spain, Belgium, Italy and France today. Canada, you also had it. So it is giving us confidence that, the overreaction is going to be something of the past, hopefully.
Dr. Kekonya, here's another question by Fundi Martin. He says, does one have to get tested for COVID-19 before getting vaccinated? If not, what happens if a positive person is vaccinated?
No, Jeff, that's a good question, but the tests that check for COVID are two types. One, you can check with a swab to see whether you have ongoing active disease, or you could check for in the blood whether you have antibodies, a history of having been exposed in the past. However, we know that receiving a vaccine in somebody who already has had the disease has not shown any major reactions. So there will be no value in being tested first, because even if you get tested and you are proved to have had the virus, there's still some value in getting the vaccine. But as I said earlier, if you have had COVID and somebody else hasn't had, and you have the same risk factors, and there's only one vial available, please give it to the person who hasn't had it. Because if you have had it, you have a bit of small immunity. We don't know how long it will last, because again, it's a new disease. Time will tell. But we know for sure that you are a little less at risk than the person who has not been exposed. But if you have multiple risk factors, and even if you have had COVID and there's a vial available, please take it.
Dr. Kekonya, real quick on that point, do you know anybody who has walked into your hospital who has had COVID twice, who has tested twice for COVID?
Yes, the answer is yes, Jeff. There are not many, but yes, it's true. I have seen people who no, let's make it quite clear. Not people who had COVID twice, because COVID means that if you have had symptoms, you are sick, you are admitted, you come again. I've not seen that one. But COVID testing positive twice over a period of 4 to 6 months, the answer is yes. I know people who tested last year in June, July, August, and they were positive. And they again, early this year, they have tested positive. Yes, I've seen a few people testing positive twice, but I've not seen anybody getting sick twice.
Good point, good point. So people like us shouldn't think we are immune because we got tested positive, right? You and me.
That's true.
Okay, all right.
That is true. But we are. There's no doubt that we are at less risk of serious complications than a fully immune person.
Understood. Dr. Mutwiri has a question for Dr. Willis. He says, Dr. Willis, a quick one. What alternative do you have for healthcare workers who are allergic to eggs since they were advised not to take the vaccine?
Yeah, this is something that keeps coming, and I hope today I can put this to rest. That vaccines have different platforms in which they are made from. There are some vaccines that have been made using an egg protein, I think called physotin or something, if I remember my biochemistry. But the Astrazeneca vaccine has not been made from an egg protein. Now, I know within our guidelines, we talk about that because it's not only Astrazeneca we are going to deploy. We are going to deploy many others. But there will be different operational guidelines for each of them. So the general one, yes, allergy like egg was mentioned. Actually, my task force decided to remove it as we deploy AstraZeneca because AstraZeneca vaccine is not made from egg protein. So it is not a contraindication. If you have egg, you don't take eggs, you can still get a shot of AstraZeneca. But if any of the other vaccines may lead to that, then you stop. However, we talk of severe allergies. So what we've said, when you go to get your shot, discuss with the health worker. If you have very severe allergies and you are able to explain, then they can advise you against taking a shot.
So Dr. Mutwiri, feel free to take a shot, right?
Yeah, if it is only to do with eggs, yes. For AstraZeneca.
Correct.
To be specific.
Thank you. Dr. Mugira, here's one question from D. Matthew. He says, is the vaccine being administered to HIV positive persons? How about cancer patients and those living with underlying conditions? Doctor?
Yes, the vaccines are being administered. The difference between this vaccine and the other vaccines that we are used to is that you are not receiving a part of the virus. You are receiving a protein which your body knows what to do with. Your body receives this protein and it generates antibodies which remain ready to protect you against the virus. Therefore, we have patients with HIV, patients with cancer, even patients with very severe conditions like severe heart disease, lung disease. All patients now, as long as they are not critically ill, they don't have another infection going on, they are eligible to take the vaccine.
Good. Okay. Thanks for that. Wamaride says, Dr. Willis, maybe you can answer this. Doctor, COVID-19 infects children too. What is the vaccination plan for them?
Yeah, as Dr. Dan Gikonyo said, these are children who will be infected. The death rate is so low, less than even 0.1% or so. And so they're not at high risk of death like the 60 plus old. And also these vaccines have not been approved for use in children. In fact, that's a very critical point because people have been saying, oh, your plan is to take 3 years. The truth of the matter, our 15.8 million that we are targeting to vaccinate is the adult population. But once the vaccines then become approved for children and there is need to vaccinate them, they will really be the last people on the queue.
Dr. Gikonyo, are you telling, I'm sure that a lot of parents bringing their kids, the kids who test positive, well, yeah, are you giving them that advice? Obviously, this AstraZeneca is not approved for people under 18, I guess, children under 18. But what advice are you telling the parents of the kids who test positive?
No, the guidelines are quite clear that this vaccine is not to be used for young people for two reasons. One, because the studies that have been done on the vaccine have not been done on these young people. Two, these people are not at high risk of complications from this disease. And therefore, even if they were able to tolerate it, it will not be much value to them. And three, these vaccines are not available in large quantities, and therefore it should be given to the people who really need them. As people who come, that have seen kids who have tested positive, the risk of these kids is not to themselves, is to Jeff's people like me, grandparents, because we want to hug them and want to play with them. we are the ones at risk from getting infected from them. But as far as they are concerned, for them, it's just another common cold or flu. They even have no symptoms. But even the general population, remember, Jeff, that maybe as high as maybe 70–80% of people who get infected with COVID have no symptoms. It's only about 20% who really get sick from this virus. So, and that's why I'm saying many times to the people listening that we should target the people at the highest risk, because many people I've seen young people, even here in Karen Hospital, young people who test positive and they are normal. And young technicians, they are in their 20s and 30s, who are not overweight, they don't have any comorbidities, and they're just normal. They continue their things. So let us target the people who are at risk. And you know, this is not new, Jeff. We have had the other influenza viruses. That influenza, even in Europe and in America, where Mogera is, other places, influenza is a disease that's high risk for people of a particular age group, 70 and above. And even in vaccines, the ordinary flu vaccine has guidelines that we give it to those people at that age group, or people who are exposed, or people like us who are in the front line who have these viruses often. Even the flu vaccine that we give these days is not given to everybody. It's given to a particular target group. So we should also focus on this COVID vaccine for those target groups, not for everybody, for sure. And remember, today we are talking about the Astrazeneca vaccine. It is different from the other Moderna and Pfizer vaccines. So the things you're talking about here, in my view, or what I've talked about, is appertaining to AstraZeneca vaccine, which has a different mode of action from Moderna, from Pfizer. When we come to other types of vaccines that target messenger RNAs and DNAs, that's a different group altogether. But this one, for children, the answer is they are safe. We just tell them to keep away from their grandparents, not because they will get sick from them, but because they will give the virus to them.
Absolutely,
so
good point.
Disadvantage to their grandchildren. Yeah.
Okay, good. I'm glad you talked about viruses, because Samuel Minor is asking the question. Maybe Dr. Willis, you can answer this.
Yes.
Ask Dr. why are we not procuring the Sputnik, I think it's Sputnik V they call it, or Sputnik V vaccine from Russia, which we hear is the best in terms of eliciting immunity?
Yes, let me start by saying first our guidelines in terms of what the country adopted on the advice of the Immunization Technical Advisory Group. What is very important, that these vaccines must have a stringent regulatory authority authorization. And the stringent regulatory authority is the US FDA, is the European Medicines Agency, is the UK MH something A. It is the Swiss Medic, and I think the Japanese one. Those are, and WHO. So for Kenya, yes, WHO will look at it as stringent regulatory. Now within the COVAX mechanism, which has the subsidy, you also have to have that stringent regulatory authority. Currently under the COVAX mechanism, we have Pfizer, Moderna, and AstraZeneca. We hear Sputnik has applied, Johnson & Johnson is also applying. So whichever go there, then we will have that choice. But as of February, when we wanted these vaccines, actually Moderna didn't have any doses and Pfizer had very limited doses. So AstraZeneca was there. Now, but let me also say that our Pharmacy and Poisons Board have reviewed Sputnik and given it local registration. So we require two things: local registration and stringent regulatory authorization for us to be able to procure.
So eventually it could end up here?
Yeah, it could, yes.
Yeah, like Johnson & Johnson maybe.
Yes, as well.
Very good. One last tweet, I think Nyangano says, Dr. Kwale, the vaccines are being dispatched to counties. These vaccines are supposed to be stored under special conditions. Has the ministry ensured that all counties have storage facilities that meets the standard?
Yeah, so let me say that within the counties we have what we call the regional stores, and there are 9 of them according to the old provincial headquarters, and Rift Valley has 2, Eldoret. Now the vaccination posts, actually the delivery is from the vaccine stores to the vaccination post. There you need a refrigerator that is able to maintain 2 to 8 degrees. For AstraZeneca, 2 to 8 degrees. If it is Moderna, you need -20, and if it is Pfizer, it's the -70 degrees that you require. And that is why it became a little bit logical to start with the introduction of AstraZeneca. Now, I know that the counties do not have storage facilities, because currently it is that, except for 3 counties, the plan is to try and see that another 44 counties are able to get what we call walk-in storage, so that the turnaround time to get vaccines, especially as more vaccines come in, including, you know, the country is considering bringing in vaccines like for typhoid, like for meningitis. There will be other vaccines coming. So that is the time that would start to require to expand storage facilities within counties.
Okay. Dr. Mugire, let me ask you this question, or let me direct this question at you from no other than Fred Obach-Machoka. I'm sure you've heard of him all the way in Kansas. He's asking, look, when did the flu exit and corona enter? Or did corona take over the common colds and flu? Where does one draw the line? Actually, I can't remember the last time I had a flu, I had a cold. When does one draw the line?
Thank you, Obachi, for that question. The truth is that we are still seeing flu. We are still seeing flu, except the way flu is transmitted is the same way coronavirus is transmitted. Therefore, when you institute precautions which are meant to prevent the transmission of coronavirus, what you do is that you also institute measures which control the transmission of flu. So we are still seeing patients who come in with both flu and COVID, or COVID by itself, or flu by itself. We have always known for a long time that social distancing makes a big difference in terms of the transmission of flu. For the first time in hospitals across the United States, we have had very few deaths of flu in children. That's because we have limited the transmission by the precautions that we are taking. So flu is not gone. It's just that the precautions the very intense precautions coronavirus forced us to put in place have also benefited in reducing the prevalence of flu.
Yeah, good point. Okay, Dr. Willis, just reinforce this point. Maina Kageni, he must have missed the first part of this show, so let's remind him. He's asking, are we really doing enough testing? Are you happy with our depth of testing? You answered that before, but answer, just in case Maina joined us late.
Yeah, it is improving, and you can see from the numbers, something like 6,000 tests per day. There was a time we were hardly doing 1,000. I know the ministry has worked hard, and it now has enough tests. And that's why we are picking quite a number of this current wave. And it's the testing that really has given us that signal. We are in the 3rd wave. We are doing well in terms of testing.
And how many do you project going forward per day in terms of tests, vaccines rather?
We would want to be in the range of 6,000–7,000 tests per day.
And vaccines per day?
Oh, in terms of vaccines, vaccines we want to ramp up. We are now doing 4,000 to 5,000, as I said, and this is within the very first week. We want to be between 15,000 and 20,000 per day. That's what we are aiming at, our cruising height.
All right. Gentlemen, I'm going to get closing thoughts from you going forward. Dr. Mugire, you're all the way out there in what they consider the first world. Look over the continent, over the Atlantic. Look at us for a moment with all the doubts that are coming out, all the hesitation, all the misconceptions. What do you tell Kenyans right now going forward from where you're sitting right now?
From where I'm sitting, I would tell you that if you have the opportunity to take the Astrazeneca vaccine, take it. And that's for several reasons. Logistically, it's going to be almost impossible to deliver the Pfizer vaccine to rural areas in Kenya, or even in urban areas. Maintaining a cold chain of -70 and -20 for a vaccine is almost going to be impossible. That's number one. Number two, the AstraZeneca vaccine is the only vaccine that was tested majorly among younger people between 30s and 60s. Pfizer and Moderna had more people who are older. So if you have an opportunity to take this vaccine, I would say go ahead and take it.
Very good point. Thank you, Doctor. Dr. Dan Gikonyo, your closing thoughts going forward as well. What do you tell the people listening, watching tonight?
Thank you. Thank you, Jeff. Let me start by saying that COVID has been, in some ways, very good for us, in the sense that, as Mogere has said, the rate of common colds and flus and diarrheal diseases has gone down because people are washing their hands, they are keeping distances, they are wearing masks. So it has had effect on many other communicable diseases, which is good. The curfew has reduced accidents and the trauma in our casualty departments. That's a good point. As I am a scientist and I've read about the Sputnik vaccine, Jeff, if I got it, I would use it. It is more effective than the Astrazeneca, and it is on the same modalities of action as AstraZeneca. And please, if we can get it from the Russian embassy or anybody else, I am willing to use Sputnik. Number 3, let me challenge our young scientists in Cambridge and other research areas, in Cliffy and other places. Please, let us not be just dependent on people giving us vaccines. We cannot be dependent on people to save ourselves. Here in Karen, we open the heart, we repair it, we put valves, we stitch it, just like anybody else in New York or Melbourne. If we can do that on our line, surely the people who are doing research in Cambridge and other places can produce this vaccine for us. We cannot be dependent on the West for the rest of our lives. And that's my parting shot.
I love it, Doctor. Thank you so much. Dr. Willis Akhwale, you get the final word. Your thoughts going forward.
Yeah, thank you very much. Let me first start by thanking the task force that I had. It's been a lot of effort to reach where we are. And the main purpose and why the ministry is really focused on this is that this is an extremely important arsenal in our fight against coronavirus that has had a major socioeconomic impact in this country. People have lost jobs. The other day I was talking to a friend. We have people with comorbidities. For the last 1 year, religiously, they don't leave their homes. They don't go shopping. They don't go to places of worship. They're just that idle within the homes. Now we have this vaccine that can make a difference. It is therefore free. Take that opportunity. Do not read so much in the social media. There's a lot of misconception and misinformation. There are people speaking English but peddling a lot of misinformation there. The experts are here. Today you've seen this panel here. With the right information, get that right information, make a decision. It is voluntary, but it will make a difference between life and death. Thank you very much. I have been vaccinated. You need to be vaccinated.
Well done, Doctor. And you just felt a little numb in the hand. Next day, you were fine.
Yes.
Dr. Willis Akhwale, Dr. Dan Gikonyo, Dr. Job Mogire, thank you so much. Gentlemen, that's been a great conversation. And I hope we've reassured Kenyans as much as we can.
Yeah.
Let's take this vaccine going forward. Thanks so much for being a part of JKLIVE. By the way, before we go away, we have some breaking news from Tanzania right now. We're going to go straight to TBC in Tanzania. Take a look at this right now. Breaking
Jamhuri ya
news.
Muungano wa Tanzania, Mheshimiwa Dr. John Pombe Joseph Magufuli